symptoms of mania. The difference is hypomania doesn't impair the person's ability to function. In other words, if they're manic, they can't be still long enough to work or participate in family things. But in hypomania, they're excited and they're in a really active phase. I don't know how else to describe it. In hypomanic episodes, it doesn't impair the person's ability to function. In fact, he or she may be quite productive. And there are no psychotic hallucinations. A mixed episode is diagnosed when the person experiences both mania and depression nearly every day for at least 1 week. These mixed episodes are often called rapid cycling. For the purpose of medical diagnosis, bipolar disorders are described as follows. There's a really good diagram of bipolar disorder. I don't know why they don't put it with this one. Hang on, I'm going to find it. And I don't know why I didn't write the page number down. I don't know about that either. Oh, come on. My thumbs are not working again today. I'll find it. Hang on.
306.
All right. Who found that? Raise your hand. Nobody's claiming it. Oh, there you go. It was Jacqueline. Okay, so look at on page 306. I'm going to write this down, okay? Hang on. So if you can read these little squiggles that go up and down. So in bipolar mixed, you can see that first kind of brown color. You've got both. You've got cycling between mania, normal mood, depression, normal mood, mania, and so forth. So they go back and forth. In bipolar 1, they have manic episodes with at least one depressive episode. So you see that one loop down to the depressive part. And in bipolar 2, they have recurrent depression episodes with at least one hypomanic episode. So they don't go all the way up to mania, but they go up to hypomania. I'll explain rapid cycling to you briefly. I had a student, let me back up. When we met at the hospital in Madison, we met in this little tiny classroom, or some kind of room. And then I would divide up the students. There were 5 departments, and they would spread out and go all over the place. And so we went as a group, and then I would just drop off whoever was in that department. So we're going to the elevator to go to our different departments, and one of the students was missing. And so the elevator opened, and there were nurses and whoever in the elevator, and I said, y'all go ahead, we'll wait. And the student did not appear, and so I just told everybody, go on without me. And I went back to get the student, and she was sitting on the floor crying. And of course, me being the mental health instructor that I am, I said, get up, let's go. so she got up, and we went to the elevator. She said on the way something about her dad couldn't keep her kids, and she had all these personal things going on. So we went, we had our day, and at the end of the day, we were doing our post-conference, and she was just on top of the world. She was talking so fast and so much that nobody else got to tell about their day. And so that's rapid cycling. She went from way down, depressed, whatever, to this hyperactivity. And I wasn't a very good instructor that day. I just didn't have time for it. I'm sorry. But we're all human. Hopefully you won't be that nurse. Okay? Don't be that nurse. So we got our bipolar 1 disorder, one or more manic episodes or mixed episodes, usually accompanied by major depressive episodes. So we're up and down. And bipolar 2 disorder, one or more major depressive episodes accompanied by at least one hypomanic episode. So it can be either one, it can be kind of a combination. So you've got just about everything with bipolar disorder. You can't say it's one or the other. Okay, people with bipolar disorder may experience a euthymic or normal mood and affect between extreme episodes, or they may have a depressed mood swing after a manic episode. For some, euthymic periods between extremes are quite short. For others, euthymia lasts months or even years. So you never know what you're going to get, right? What does Forrest Gump say? Like, life's like a box of chocolates. All right. So let's look at related disorders. There are multiple related disorders. Persistent depressive or dysthymic disorder is a chronic persistent mood disturbance, characterized by symptoms such as insomnia, loss of appetite, decreased energy, low self-esteem, difficulty concentrating, and feelings of sadness and hopelessness that are milder than those of depression. So we've got low self-esteem and hopelessness in that same paragraph. So that's persistent depressive disorder or dysthymic. Disruptive mood dysregulation disorder is a persistent angry or irritable mood punctuated by severe recurrent temper outbursts that are not in keeping with the provocation or situation. And this begins before age 10. So highlight that. Psychothymic disorder is characterized by mild mood swings between hypomania and depression without loss of social or occupational functioning. Substance-induced depressive or bipolar disorder is characterized by significant disturbance in mood that is a direct physiological consequence of ingested substances such as alcohol, other drugs, or toxins. Seasonal affective disorder has two subtypes. One is fall onset, one is spring or summer onset. It's when the person is affected generally by the sun, how much sun they get, what's going on around. It's like I said about the suicide, about when everything blooms and it gets all summery and whatever. Those people are down, so they're backwards. I had a friend that had this special light that she would sit beside where in her den to keep her from getting in that sad mood in the winter, in the fall and winter. Postpartum or maternity blues is a mild, predictable mood disturbance occurring in the first several days after delivery of a baby. Symptoms include labile mood and affect, crying spells, sadness, insomnia, and anxiety. The symptoms subside without treatment, but mothers do benefit from the support and understanding of friends and family. That's those women that cry one minute and are happy the next, and it goes away. It's not a big deal. A lot of people have it. Postpartum depression, however, is the most common complication of pregnancy in developed countries. The symptoms are consistent with those of depression, with onset within 4 weeks of delivery. All right, so that's different than the baby blues. Postpartum psychosis is a severe and debilitating psychiatric illness with acute onset in the days following childbirth. Symptoms begin with fatigue, sadness, emotional lability, poor memory and confusion, and progresses to delusions and hallucinations. So that's the most severe kind. Those women need to be hospitalized and given medication. Um, these are those women who drown their children. I know you've all heard that. I don't really teach the premenstrual dysphoric disorder. That's PMS, right? I never had it, so I don't know about it. I'm not sure I believe it. Does anybody suffer from PMS? No? Nobody? Good, I don't believe it. No, I'm kidding. Non-suicidal self-injury involves deliberate, intentional cutting, burning, scraping, hitting, or interference with wound healing. The cutters are usually bipolar. That's just one of the characteristics of bipolar disorder. I had a student once who had scars from her wrist to her elbow where she'd cut herself. A lot of times they'll do it where you can't see it, like their thighs or somewhere that's covered, okay? Etiology. Various theories for the etiology of mood disorders exist. The most recent research focuses on chemical biologic imbalances as the cause. Nevertheless, psychosocial stressors and interpersonal events appear to trigger certain physiological and chemical changes in the brain, which significantly alter the balance of neurotransmitters. So we're back to the neurotransmitters being part of the problem. Okay, biologic theories, and they're just that, theories. So we've got genetics. It says, genetic studies implicate the transmission of major depression in first-degree relatives. What are first-degree relatives? Mom, dad, brothers, and sisters. It's that close community. It's not going to be cousins and whoever. First-degree relatives of people with bipolar disorder have a 7-fold risk for developing bipolar disorder compared with a 1% risk in the general population. For all mood disorders, monozygotic, meaning identical twins, have a concordance rate, meaning it's the same. Both twins having the disorder 2 to 4 times higher than that of dizygotic or fraternal twins. And that's because they have the identical DNA, right? They're just alike. Although heredity is a significant factor, the concordance rate for monozygotic twins is not 100%. So genetics alone don't account for all mood disorders. There are also indications of a genetic overlap between early onset bipolar disorder and early onset alcoholism. People with both problems have a higher rate of mixed and rapid cycling, poorer response to lithium, which is the drug of choice, slower rate of recovery, and more hospital admissions. Mania displayed by these clients involves more agitation than elation. Clients may respond better to anticonvulsants than to lithium. All right, the neurochemical theories. Here we go with serotonin and norepinephrine, right? Neurochemical influences of neurotransmitters focus on serotonin and norepinephrine as the two major biogenic amines implicated in mood disorders. Serotonin has many roles in behavior: mood, activity, aggressiveness and irritability, cognition, pain, biorhythms, and neuroendocrine processes. Deficits of serotonin, its precursor, tryptophan, or a metabolite, and it gives you this 5-hydroxydole acid, whatever, found in the blood or cerebral spinal fluid occur in people with depression. So, what does that mean? Serotonin may be increased, right? In depression. Increased in depression. You can write that in your margin. Make an arrow. Okay. Positron emission tomography, which is a PET scan, demonstrates reduced metabolism in the prefrontal cortex, which may promote depression. Now, did I tell you wrong? Wait a minute.
It should be deficit, right?
Yeah, it should be. I was just reading. Got my arrow going in the wrong direction. You can't trust me sometimes. All right, norepinephrine levels may be deficient in depression and increased in mania. I got that right. I got that one. Okay. This catecholamine energizes the body to mobilize during stress and inhibits kindling. Kindling is the process by which seizure activity in a specific area of the brain is initially stimulated by reaching a threshold of the cumulative effects of stress, low amounts of electric impulses, or chemicals such as cocaine that sensitize nerve cells and pathways. So kindling causes seizures. It's all that activity going at once, okay? It's an increase in everything. These highly sensitized pathways respond by no longer needing the stimulus to induce seizures. In other words, they'll happen anyway. Anticonvulsants inhibit kindling. This may explain their efficacy in treating bipolar disorder. So we got anticonvulsants that we can treat it with. Dysregulation of acetylcholine and dopamine is also being studied. So it's being studied, and I'm not going to go into that. If it's just being studied, it's not a real thing, right? I'm really funny early in the morning. Don't y'all find that to be true? Yes. Oh. Okay. Neuroendocrine influences. Mood disturbances have been documented in people with endocrine disorders, such as those of the thyroid, adrenal, parathyroid, and pituitary glands. Thyroid is the big deal, usually. That's why the new thing that they talk about on TV is related to thyroid. What is that disorder? Something, never mind. Okay, so about 5% to 10% of people with depression have thyroid dysfunction, notably an elevated thyroid stimulating hormone, that's TSH. This problem must be corrected with thyroid treatment, or treatment for the mood disorder is adversely affected. Okay, psychodynamic theories. I like to blame the victim part. Many psychodynamic theories about the cause of mood disorders seem to blame the victim and his or her family. They include the following beliefs or suppositions, okay? The self-deprecation of people with depression becomes self-reproach and anger turned inward. That was Freud's idea, okay? Anger turned inward, related to either a real or perceived loss. Feeling abandoned by this loss, people are then angry while both loving and hating the lost object. A person's ego or self aspires to be ideal and loving, superior, strong, and that to be loved and worthy, they must achieve these high standards. Depression results when in reality the person is not able to achieve these ideals all the time. So that's your ego. The state of depression is like a situation in which the ego is a powerless, helpless child who is victimized by the superego, much like a powerful and sadistic parent who takes delight in torturing children, not tutoring, but torturing. Sometimes tutoring can be torture. Okay. All right. The state of depression is like a situation in which the ego is a powerless, helpless child who is victimized by the superego, much like a powerful and sadistic parent who takes delight in torturing the child. Most psychoanalytical theories of mania view manic episodes as a defense against underlying depression, with the id taking over the ego and acting as an undisciplined, hedonistic being, like a child. Depression is a reaction to a distressing life experience, such as an event with psychic causality. See, I can't even read. Causality, not casualty. God. Oh, Lord. Somebody want to take over? Children raised by rejecting or unloving parents are prone to feelings of insecurity and loneliness, making them susceptible to depression and helplessness. Depression is a result of specific cognitive distortions in susceptible people. Early experiences shape distorted ways of thinking about oneself, the world, and the future. I wrote everything in my margin. These distortions involve magnification of negative events, traits, and expectations, and simultaneous minimization of anything positive. So these are psychodynamic theories. I can see how people would be affected by most of these. Not everybody, not all of them, but depression can happen to anybody. The clinical depression is the one you have to worry about. That means it's diagnosable, okay? It's not one day. All right, cultural considerations. Other behaviors considered age-appropriate can mask depression, which makes the disorder difficult to identify and diagnose in certain age groups. So when somebody acts like a child, we're just saying they're childish, right? It could be more than that. So we have to be careful. Many somatic ailments, physiologic ailments, accompany depression. This manifestation varies among cultures and may be more apparent in cultures that avoid verbalizing emotions. For example, some people may report multiple physical problems, backaches, headache, and heart problems. How they are experiencing depression may be related to cultural norms or beliefs. So we have to be careful with people from other cultures, other countries. Major depressive disorder, MDD, typically involves 2 weeks or more of a sad mood or lack of interest in life activities, with at least 4 other symptoms of depression, such as anhedonia and changes in weight, sleep, energy, concentration, decision-making, self-esteem, and goals. Major depression is twice as common in women and has 1.5 to 3 times greater incidence in first-degree relatives than in the general population. Incidence of depression decreases with age in women and increases with age in men. Single and divorced people have the highest incidence. Depression is pre-pubertal. In pre-pubertal boys and girls occurs at equal rate. So, if you're single and divorced, you have the highest incidence. So, if you're divorced, you're already in a bad place, right? Or you may be in a good place. Some people are better. All right, the depression comes before the divorce sometimes, right? All right, psychopharmacology. Major categories of antidepressants include cyclic antidepressants, monoamine oxidase inhibitors, selective serotonin reuptake inhibitors, and atypical antidepressants. Chapter 2 details biologic treatments. The choice of which antidepressant to use is based on the client's symptoms, age, and physical health needs. Drugs that have or have not worked in the past or that have worked for a blood relative with depression and other medications that the client's taking. So it could be anything. So there again, chapter 2 is not something I teach, but you should refer to it whenever we talk about these drugs, okay? Researchers believe that levels of neurotransmitters, especially norepinephrine and serotonin, are decreased in depression. Usually presynaptic neurons release these neurotransmitters to allow them to enter synapses and link with postsynaptic receptors. Depression results if too few neurotransmitters are released. Okay, so if they're down, you may get depression, right? If they're low. If they linger too briefly in synapses, if the releasing presynaptic neurons reabsorb them too quickly, if conditions in synapses do not support linkage with postsynaptic receptors, or if the number of postsynaptic receptors has decreased. Chapter 2 has a really good diagram of those synapses and the presynapses. If you're a visual learner, which I am, that might help you understand that. How many visual learners do I have? None? Raise your hand. None? Oh man, I am. Yeah. You can tell me all day, and I can read it. But until I see that diagram of what's going on, I'm kind of out there. Okay, the goal of neurotransmitters is to increase the efficacy of available new neurotransmitters and the absorption by postsynaptic receptors. To do so, antidepressants establish a blockade for the reuptake of norepinephrine and serotonin, so that selective serotonin reuptake inhibitor, that's what it's doing. It's blocking the uptake of these neurotransmitters. This permits them to linger longer in synapses and to be more available to postsynaptic receptors. Antidepressants also increase the sensitivity of the postsynaptic receptor sites. In clients who have acute depression with psychotic features, an antipsychotic is used in combination with an antidepressant. The antipsychotic treats the psychotic features. Several weeks into treatment, the client is reassessed to determine whether the antipsychotic can be withdrawn and the antidepressant maintained. Evidence is increasing that antidepressant therapy should continue for longer than the 3 to 6 months originally believed necessary. Fewer relapses occur in people with depression who receive 18 to 24 months of antidepressant therapy. As a rule, the dosage of antidepressants should be tapered before being discontinued. So if your client calls and says, I'm not taking this crap anymore, then you're going to have to tell them they can't stop it. It has to be a tapering dose. If they're going to change medications, they will decrease the one they've been on and start the other one and increase it until it reaches a therapeutic level. You don't want to just stop them immediately. Diagnostic criteria for major depressive disorder is listed on page 289. Well, I don't want to go through this whole thing. I'll tell you what I've got underlined in my book. Significant weight loss, not dieting, or weight gain, and it gives you the figures, or decrease or increase in appetite nearly every day. Okay, so that's the weight thing. It can be up or down. And then it talks about sleep, insomnia or hypersomnia, and then psychomotor agitation or retardation. fatigue or loss of energy, worthlessness or excessive or inappropriate guilt, diminished ability to think or concentrate, recurrent thoughts of death, not just fear of dying, recurrent suicidal ideation without a specific plan or a suicide attempt, or a specific plan for committing suicide. What did I say? You've got to have the idea, right? You've got to have a plan, and you've got to have the means to do it. Those three things. The symptoms cause clinically significant distress or impairment in social, occupational, or other areas of functioning. It says, note criteria A and C represent a major depressive episode. So A and C. A is 5 or more of the following symptoms. C is the symptoms cause clinically significant distress.
Well, it says A2C, so that would be B2, right?
I'm sorry. Say that again.
It says A2C, so that would be B as well, right?
Oh, yeah, I'm sorry. So, and B, they do not include symptoms that are clearly attributable to another medical condition, and then it goes into 1, 2, 3, whatever. Yeah. A to C. Okay. That was able to stop me. Okay. Now we're going to talk about drugs. Look at page 292 and 290 and 291 on table 17.1, SSRI depressants. I have only marked in my book Prozac, Zoloft, and Paxil, first three. And then table 17.2 is the tricyclic antidepressant medications. And the only ones I have marked, Cinequan, which is doxepin, and Pamelor, that last one at the bottom. And we'll talk about these. All right, so SSRIs are more frequently prescribed because they have fewer side effects. And if you look at their side effects, they are mild. I was going to mention one. They usually cause dizziness, dry mouth, headaches sometimes, vomiting and diarrhea are rare, but they list that. So if you look at these, they all have the same side effects, or just about the same. And that's why, and they're mild. I mean, if you got a headache, take a Tylenol, right? Something like that. But they're mild side effects. If you look at some of the ones with the tricyclics, they're a little more severe. They have cardiac symptoms and dysrhythmias and orthostatic hypotension and some other things. So they would try the SSRIs first. Because of their low side effects and relative safety, people using SSRIs are more apt to be compliant with the treatment regimen. So if they have fewer side effects, they'll take them, right? So when they start taking these, the insomnia is less, the appetite goes back to normal, their energy returns, and it gives you the number of days. I don't think I asked you that. Prozac produces a slightly higher rate of mild agitation and weight loss. When it first came out, women were taking it because it caused weight loss. But less somnolence. Do y'all know what somnolence is? That's that drowsiness, limp feeling. And I don't care about half-life. Cyclic antidepressants, tricyclics in particular, introduced for the treatment of depression in the 1950s are the oldest ones, okay? They relieve symptoms of hopelessness and helplessness, anhedonia, inappropriate guilt, suicidal ideation, and daily mood variations. Other indications include panic disorder, obsessive compulsive disorder, and eating disorders. Each drug has a different degree of efficacy in blocking the activity of norepinephrine and serotonin, or increasing the sensitivity of the postsynaptic receptor sites. This next little bit you need to underline, or whatever you're doing. Tricyclic and also heterocyclic antidepressants have a lag period of 10 to 14 days before reaching a serum level that begins to alter symptoms. They take 6 weeks to reach full effect. And that's what you need to tell your patients, okay? They're not going to feel good tomorrow. It's going to take 10 to 14 days before they begin to feel better, right? And 6 weeks to reach that full response to the medications. It says, because they have a long serum half-life, there's a lag period of 1 to 4 weeks before steady plasma levels are reached and the client's symptoms begin to decrease. So that's what you need to teach your clients, right? They cost less primarily because they've been around longer and generic forms are available. When medications are new, they charge you for research and development of those medications. That's why they're so expensive at first. You're paying for all the testing they've done. And it's like they said, they develop generics. I think all the medicine I take, which is not that much, but they have a generic brand that they give me at Kroger. Kroger likes the generic brand. All right, tricyclic antidepressants are contraindicated in severe liver impairment and in myocardial infarction. So you don't want to give them if they've got those problems. Obviously, it's cleared through the liver, right? They cannot be given concurrently with MAOIs, which we'll get to in a minute. Because of their anticholinergic side effects, tricyclic antidepressants must be used cautiously in clients who have glaucoma, benign prostatic hypertrophy, urinary retention or obstruction, diabetes mellitus, hyperthyroidism, cardiovascular disease, renal impairment, or respiratory disorders. So are you going to go to that first? No, I don't think I would give those first. Overdosage, tricyclic antidepressant occurs over several days and results in confusion, agitation, hallucinations, hyperpyrexia, and increased reflexes. Seizures, coma, and cardiovascular toxicity can occur with ensuing tachycardia, decreased output, depressed contractility, and atrioventricular block. Sounds serious, doesn't it? Good Lord, it goes on and on. I would never give these to anybody. Right? Good Lord. So let's look at atypical antidepressants on page 292. It says they are used when the client has an inadequate response to or side effects from SSRIs. Atypical antidepressants include Effexor, Cymbalta, Wellbutrin, Surzone, and whatever. I don't know that drug. So if you look at this chart, I have marked a little check mark by Effexor and Wellbutrin. Wellbutrin is about the most popular atypical antidepressant, and they use it for withdrawal from nicotine. I don't think it says that in here, but they do, okay? So it has a lowered seizure threshold. What does that mean? If the threshold's lowered, that means it might happen more frequently. So that may allow seizures. Buprofen modestly inhibits the reuptake of norepinephrine. Weekly inhibits the reuptake of dopamine and has no effects on serotonin. So we're not going to worry about that one, right? All right, let's look at monoamine oxidase inhibitors, MAOIs. They've been used infrequently because of potentially fatal side effects and interactions with numerous drugs, both prescription and over the counter. However, they may be superior to typical medications for treatment of typical and treatment-resistant depression. The most serious side effect is hypertensive crisis, a life-threatening condition that can result when a client taking MAOI ingests tyramine-containing food. You need to underline that. Tyramine-containing foods. So it lists MAOI antidepressants at the top of page 293. I have only seen Marplan and Nardil used. The thing is, if they ingest certain foods, they don't list them, do they? Well, okay. It's usually certain cheeses, red wine, the over-processed meats like pepperoni on your pizza, salami, pepperoni, some of those really aged meats. So tyramine is the thing. And it can lead to hyperpyrexia, cerebral hemorrhage, and death, okay? Not good. And they don't use them very frequently. You won't see them. You need to teach your clients about the diet with the tyramine, right? There's a 2 to 4 week lag period before MAOIs reach therapeutic levels. Because of the lag period, adequate washout periods of 5 to 6 weeks are recommended. Washout periods are that thing I was describing where you're decreasing one medication and increasing the other. So that's the washout period. And it gives you all the MAOI drug alerts, okay? So you need to be careful to teach your patient all of these things, okay? I'm not going to go through it. Gives you drug interactions. Okay, other medical treatments and psychotherapy. Electroconvulsive therapy. Psychiatrists may use electroconvulsive therapy to treat depression in selective groups, such as clients who do not respond to antidepressants or those who experience intolerable side effects. So they're going to save electroconvulsive therapy for treatment of depression that didn't get treated with other things or didn't respond to the other things. Pregnant women can take it. So that's the main thing I was reading ahead. The main thing that they use ECT for is depression. Now I have to say, now that I've said that, they use it a lot with, they will use it a lot with, God, I can't even think. Hang on. Schizophrenia, that's the word I was looking for. Yesterday when I was talking about the guy sitting in the corner talking and acting as if he were listening to something, he had been in there quite some time, and they were doing ECT on him 3 times a week. So when they say in here somewhere that they only use it a few times, that's not true. There are patients who've had hundreds of ECT treatments.
I have a friend who did it, and she did it like 3 times a week for 6 weeks.
Yeah.
And it didn't help her depression at all.
It did not.
While they were doing it, did, but once she stopped the treatment, it came back, and she still has memory loss from it.
Yeah.
For like 6 weeks that she did it, she doesn't remember anything.
Yeah, it does affect your memory. There was one patient that we had, I thought I'd never forget his name, and I have. He would be just limp as a rag, not making any eye contact with anybody, just sitting in the day room, and he would get ECT, and the next day he would just be just normal, just happy and whatever. But boy, when he hit bottom, he hit bottom. And so over the period of time that we were there, maybe a trimester, I saw that multiple times with him. And then one of the nurses said, yep, he gets better, he goes out, he does cocaine, and he winds up back here. So it was drug related. But he was a nice guy after ECT. Okay, so your atypical antidepressants are those two that I mentioned. They're the only ones that I know about. And then we go to ECT. All right, so I'm going to tell you about ECT. It says clients usually receive a series of 6 to 15 treatments scheduled 3 times a week. Generally, a minimum of 6 treatments are needed to see sustained improvement in depressive symptoms. Maximum benefit is achieved in 12 to 15 treatments. So your friend, she got them 3 times a week for how many weeks?
I think it was like 6 weeks or something like that. It was a long time.
Yeah, so 18 treatments at least that we know of, right?
Yeah.
So that's usually a last resort. They're going to try other medications first. They're going to try all the medications first.
Yeah, she had tried like 20 or 30 different medications, and nothing was helping. So this was, I think, her 3rd time doing ECT. She had done it once for postpartum depression, and then once before then as well.
Well, it either works or it doesn't. There's no middle ground. Okay, it tells you about the ECT. It's your MPO after midnight. They remove fingernail polishing. They take them to the bathroom and all this stuff. Okay. Removing the fingernail polishes so they can take your O2 sat, right? It says initially the client receives a short-acting anesthetic so that he or she is not awake during the procedure. Next, they receive a muscle relaxant paralytic, usually succinylcholine, which relaxes all muscles to reduce greatly the outward signs of the seizure. Okay, so we're trying to cause a seizure when we're doing the ECT. Electrodes are placed on the client's head, one on either side, or one unilateral, one side. The electrical stimulation is delivered, which causes seizure activity in the brain that is monitored by an electroencephalograph, EEG. The client receives oxygen and is assisted to breathe with an ambu bag. He or she generally begins to awaken after a few minutes. Vital signs are monitored, and the client is assessed for the return of a gag reflex. Until that gag reflex comes back, we're not going to give them anything to eat or drink or whatever. When they talk about making the client have this seizure, it's not like a tonic-clonic seizure when the students got to go with a patient to ECT. They said that there might be just a little wiggling of a foot all the way to a full-blown seizure. Generally not a full-blown seizure, just that little activity that you saw. When we went to the hospital in Murfreesboro, I think everybody got to see ECT. One of my students didn't want to see it, and she left. But we saw lots of them. They had like 7 beds lined up. They could give as many as 7 at a time. So it worked, obviously, or they wouldn't do them. Now your friend that it didn't work on, that's That's not typical, but it happens. After ECT, they're going to be mildly confused and briefly disoriented. They may be tired and they may have a headache. The symptoms are just like those of anyone who's had a grand mal seizure. In addition, the client will have some short-term memory impairment. After a treatment, the client may eat as soon as they feel hungry, and they usually sleep for a period. Headaches are treated symptomatically. Unilateral ECT results in less memory loss for the client, but more treatments may be needed. Bilateral ECT results in more rapid improvement, but with increased short-term memory loss. So they're going to ask you, why can't I remember? Why can't I remember, whatever it is? ECT is as effective as medication for depression in some studies, and in other studies, it reports only short-term improvement. So your friend had the short-term improvement, right?
Yeah, so her short-term memory is better now. While she was getting it done, she still doesn't remember anything. I had to take her to the hospital because she had a small blood clot in her arm from the IV.
Oh.
And she's like, what's my phone number? And I'm like, I would have to look. And, all the questions for, insurance that they asked, she's like, I don't know. She's like, I have no idea.
So she lost specific memories, huh?
Yeah. She said that, she goes, how do I spell my daughter's middle name? She goes, is it with an E or no? I'm like, how am I supposed to know how to spell your daughter's middle name?
You just never know, huh? All right, so ECT is also used for prevention of depression. I don't think they're going to do that. I'm sorry. ECT is very expensive. They're not going to use that for something that may happen, right? Clients may continue to receive treatments such as one per month to maintain mood improvement. Often clients are given antidepressant therapy after ECT to prevent relapse. Studies have found maintenance ECT to be effective in relapse prevention. So once a month, they may go and get ECT. I know the guy I was telling y'all about, I would see him in the lobby with his dad, and he had come in for a maintenance treatment. This young guy had tried to kill himself by taking a bottle of drugs and just a whole bunch of things. And it affected his mind, his thought processes, and he was unable to keep a job or anything else. So he was in really bad shape from the drugs and whatever, all the way to the ECT. All right, psychotherapy. A combination of psychotherapy and medications is considered the most effective treatment for depressive disorders in both adults and children. So when I ask you, how do you treat depression, that's your answer. Medications, excuse me, and therapy. Sorry. There is no one specific type of therapy that's better for the treatment of depression. The goals of combined therapy are symptom remission, psychosocial restoration, prevention of relapse or recurrence, reduce secondary consequences such as marital discord or occupational difficulties, and increasing treatment compliance. Interpersonal therapy focuses on difficulties in relationships. Behavior therapy seeks to increase the frequency of the client's positively reinforcing interactions with the environment and to decrease negative interactions. It may also focus on improving social skills. Cognitive therapy focuses on how the person thinks about the self, others, and the future, and interprets his or her experiences. So 17.5 describes the cognitive distortions that are the focus of cognitive therapy. So look at distortions as addressed by cognitive therapy. That's table 17.5. Absolute dichotomous thinking. That means one or the other, one polar opposite, right? Polar opposites. Tendency to view everything in polar categories. All or none, black or white. I have that underlined, so you need to probably underline that. Overgeneralization, forming conclusions based on too little information, basically is what that is. One experience was negative, then all similar experiences will be negative. Magnification and minimization, overvaluing or undervaluing the significance of a particular event. One small negative event is the end of the world, or a positive experience is totally discounted. Those are the ones that I have marked. New and investigational treatments I don't care about. Y'all know I have my things I don't care about, right? Application of the nursing process. You want to take a good history so that you have a baseline. You want to know if they've had a major depression before. You want to know if they were hospitalized for it. You want to know what drugs they've taken. Do they help? Do they not help? If they've had ECT, you want to know how long that worked for them. General appearance and motor behavior. Many people with depression look sad. Sometimes they just look ill. The posture is often slouched with head down, and they make minimal eye contact. They have psychomotor retardation, which means everything's slowed down, including their thought processes. Responses to questions may be minimal, with only one or two words, answered with only one or two words. Latency of response is seen when clients take up to 30 seconds to respond to a question. They may answer some questions with, I don't know, because they're simply too fatigued and overwhelmed to think of an answer. Clients may also exhibit signs of agitation or anxiety, such as wringing their hands and having difficulty sitting still. These clients are said to have psychomotor agitation, which means increase of body movements, which includes pacing, accelerated thinking, and argumentativeness. Mood and affect. Clients with depression may describe themselves as hopeless, helpless, down, or anxious. They may also say they are a burden on others or are a failure at life, or they may make other similar statements. They experience anhedonia, losing any sense of pleasure from activities they formerly enjoyed. Their affect is sad or depressed or maybe flat with no emotional expressions. Thought process and content. Clients with depression experience slow thinking processes. Their thinking seems to occur in slow motion. With severe depression, they may not respond verbally to questions. Clients tend to be negative and pessimistic in their thinking. They tend to ruminate. This is a good cartoon of rumination on page 296. I have too many bills. I have no money. My bills are piling up. And they just keep doing this all day, every day. Okay? It says it is repeatedly going over the same thoughts. That's the definition of ruminate. Those who experience psychotic symptoms have delusions. They often believe they are responsible for all the tragedies and miseries in the world. Often clients with depression have thoughts of dying or committing suicide. It's important to assess suicidal ideation by asking about it directly, right? We know that. We need to know if they have a plan and the means. Memory impairment is common. They may even have command hallucinations that order them to commit suicide.